The healing process. The phases of healing. The phases of tissue repair often overlap each other and can be hard to understand. The first phase is bleeding. It begins at the onset of injury, and the objective is to stop the bleeding. In this phase, the body activates its emergency repair system, the blood clotting system, and forms a dam to block the drainage. During this process, the platelets come into contact with collagen, resulting in activation and aggregation. An enzyme called thrombin is at the center and initiates the formation of a fibrin mesh, which strengthens the platelet clumps into stable clots. Phase 2 is a defensive or inflammatory phase. This focuses on destroying bacteria and removing debris, essentially preparing the wound for the growth of new tissue. During phase 2, a type of white blood cell called a neutrophil enters the wound and destroys bacteria and removes debris. These cells often reach their peak population between 24 and 48 hours after injury, reducing greatly in numbers after 3 days. After the white blood cells leave, specialized cells called macrophages arrive to continue clearing debris. These cells also secrete growth factor cells and proteins, which attract immune system cells to the wound to facilitate tissue repair. This phase often lasts 4 to 6 days, and it often is associated with edema, arrhythmia, or reddening of the skin, heat, and pain. Phase 3, or the proliferative phase. Once the wound is cleaned out and the wound enters phase 3, where the focus is to fill and cover the wound. The proliferative phase features 3 distinctive stages. 1. Filling the wound. 2. Contraction of the wound margins. And 3. Covering the wound or epithelialization. During the first stage, shiny, deep red granulated tissue fills the wound bed with connective tissue, and new blood cells are formed. During contraction, the wound margin contracts and pulls towards the center of the wound, and the third stage, epithelial cells arise from the wound bed or margins and begin to migrate across the wound bed in a leapfrog fashion until the wound is covered with epithelium. The proliferation phase lasts anywhere from 4 to 24 days. Phase 4 is the maturation phase. During the maturation phase, the new tissue slowly gains strength and flexibility. Here, collagen fibers reorganize, the tissue remodels and matures, and there is an overall increase in tensile strength, although maximum strength is limited to about 80% of pre-injured strength. The maturation phase varies greatly from wound to wound, often lasting anywhere from 21 days to 2 years. There are 4 phases of repair: hemostasis and inflammation. Epithelialization is the process of developing a membranous tissue covering, or epithelium, over exposed tissue or organs. Proliferation is 3 major events. 1. Angiogenesis, which is the growth of new blood vessels. 2. Collagen synthesis, also known as collagenization. 3. Wound contraction, the drawing together of the wound edges. And finally, the last phase is remodeling. This diagram illustrates the initial injury and inflammatory response phase of the healing process. We see in image A a cut blood vessel that bleeds into the wound. The wound is on the epidermis and the bleeding continues deep into the dermis of the skin. In image B, a blood clot forms and leukocytes clean the wound. Macrophages form in the bleeding area. In C, the blood vessels regrow and granulated tissue forms in the fibroblastic repair phase of the healing process. Finally, in D, the epithelium regenerates and connective tissue fibrosis occurs in the maturation remodeling phase of the healing process. So let's go through these phases again. In phase 1, the inflammatory response phase, healing begins immediately following injury. Injury results in altered metabolism and liberation of various materials. The initial reaction by leukocytes and phagocytes. The goals of these chemicals are to protect, localize, decrease injurious agents, and prepare the body for healing and repair. Chemical mediators are derived from invading organisms, damaged tissue, plasma enzyme systems, and white blood cells. Histamine is released from injured mast cells. This causes vasodilation and increased cell permeability owing to swelling. Leukotrienes and prostaglandins. These impact margination, or adherence along the cell walls. It increases permeability locally for fluid and protein passage, also known as diapedesis. This also facilitates exudate formation and neutrophil entrance into the injured sites. And finally, we have cytokinins. These regulate leukocytes and attract phagocytes to the area. There is a vascular response in phase 1. There is an initial vasoconstriction and coagulation occurs to seal the blood vessels, and chemical mediators are immediately released. This vasoconstriction presses the endothelial wall linings together to produce a local anemia. Followed by this vasodilation, about 5 to 10 minutes later, initially we have an increase in blood flow that is transitory. This vasodilation decreases blood flow, increasing blood viscosity, resulting in edema or swelling. The initial effusion of blood and plasma lasts approximately 24 to 36 hours. The acute inflammatory reaction can be triggered by a variety of stimuli, anything from infections, trauma, physical and chemical agents, tissue necrosis, foreign bodies, and even an immune reaction. The inflammatory process, the clot formation. This is a flowchart of the inflammatory response sequence. The steps are as follows. First, we have an injury to a cell. Then chemical mediators are liberated, namely histamine, leukotrienes, prostaglandins, and cytokinins. Next, a vascular reaction occurs where vasoconstriction leads to vasodilation, after which exudate creates stasis. Then platelets and leukocytes adhere to vascular walls. Then we have phagocytosis and eventually a clot formation. The platelets adhere to exposed collagen fibers, leading to the formation of a clot, or also known as a plug. The clot obstructs the lymphatic fluid drainage, and we end up with a localized injury response. This requires conversion of fibrogen to fibrin. In the first stage, we have a fibroplastin that's formed. In the second stage, prothrombin is converted to thrombin because of the interaction because of the thromboplastin. Hemostasis and inflammation. This is the same as hemodynamic, leukocyte migration, and the phagocytosis phases of inflammation. Hemostasis is arresting bleeding or the opposite of hemorrhaging. At this point in time, macrophages are scavenging cellular debris. The circulatory and lymphatic systems are removing free proteins from the area. The more protein that stays in the area, the bigger the scar is going to be for the patient. For the lymphatic drainage system and exercise, we can either remove this through passive or active movement. The amount of movement and the amount of lymphatic drainage depends on the external force that is needed to promote fluid movement. We can use contractions, either muscle contractions or actual movement of massage, to squeeze the lymphatic vessels and force the contents of the fluid towards the vascular system. As I said, we can also use massage or intermittent compression pumps to promote lymphatic drainage. Epithelialization. This is the process of developing a membranous tissue or tissue covering epithelium over exposed tissue or organs. For proliferation, there are 3 major events. 1. Angiogenesis, or the growth of new blood vessels. 2. Collagen synthesis, also known as collagenization. And 3. Wound contraction, the drawing together of the wound edge. There is a transient phase in which new vessels are formed, and most of them later disappear. New vessels are necessary to deliver great amounts of oxygen and nutrients to the wound for repair. This typically occurs 4 to 6 days post injury. There is capillary budding. The capillary budding is the primary mechanism of the vascular phase. During capillary budding, the endothelial cells of the existing vessel at the edge of the wound begin to divide. Phase 2, the fibroblastic or repair phase. The proliferation phase occurs from days 3 to 21. During this phase, development of new blood vessels or angiogenesis occurs. The scar formation occurs through two phases: resolution, which little tissue is damaged and normal tissue restoration occurs, and regeneration, which is replacement of tissue by the same tissue. The fibrous tissue or fibroplasia can also occur, and the generation of new epithelial cells or reepithelialization occurs. Complaints of pain and tenderness gradually subside during this period. There are different types of repair, either reconstitution or replacement. Reconstitution occurs in cells that normally have a high rate of turnover. Most of the damaged cells are replaced by identical cells. Some of the replacement can occur with connective tissue, thus some scar formation can occur. In replacement, we have replacement by simpler cells. This results in the replacement of tissue in scar tissue formation. The type of repair is also known as repair by connective tissue. This can either be primary union or by a secondary union. For proliferation, we have three major events: angiogenesis, the growth of new blood vessels; collagen synthesis, also known as collagenization; and wound contraction, the drawing together of the wound edges. In angiogenesis, there is a transient phase during which new blood vessels are formed, and they later disappear. Capillary budding is the primary mechanism of the vascular phase. Endothelial cells of the existing vessel occur at the edge of the wound. They begin to divide. The new cells crawl away but keep in contact with the existing vessel. New cells force themselves between the existing cells, thus forcing the end cells to advance into the wound area. The adjacent buds sprouts migrating towards one another, meeting and uniting, and creating capillary arches. Arches form a network or capillary arcades. Blood then begins to flow through, causing a new budding. This gives free circulation to the wound area to support colonization. Collagen synthesis. Most collagen is laid down within 15 to 20 days after the injury. The wound is not yet very strong. Collagen will realign parallel to the lines of force that is applied to the tissue. Realignment sometimes can take up to a year to occur, and it may be longer if a patient is inactive or refuses to move the tissue. Healing wounds normally do not have all the oxygen that they actually could use. Collagen accumulated in the damaged tissue and in the tensile strength of the skin wounds are typically linearly related to the oxygen availability. The charts on this slide include increasing oxygen for air breathed by injured laboratory rats between days 5 and 15. These tables resulted in greater tensile strength of their wounds for these rats, indicating greater tensile strength and greater healing for these rats by increasing oxygen availability during the healing process. Wound contraction. This is the pulling together of the wound edges during the healing process. The primary player during this process is the myofibroblasts. The more of the myofibroblasts that are available, the smaller the wound ends up being. So the less collagen is needed to close the wound, and therefore the smaller the scar. Collapsing and compressing the capillary arcade, we see collagen is relatively inactive tissue. We do not need much oxygen, and therefore we do not need very much circulation. Collagen fibers reorganize themselves from haphazard alignment to parallel arrangements based upon the forces they are subjected to. This results in a compacted scar and giving the scar and underlying tissues greater strength. If collagen fibers are running perpendicular to the lines of force, they will not help keep the edges of the wound together. If collagen fibers run parallel to the lines of force, we see a strengthening in the injured tissue. Exercise helps realign these collagen fibers along the lines of force. Active exercise is necessary during final phases of wound healing. Rest at this phase of healing is counterproductive. So, as we've discussed in different parts of class already, movement is essential for the healing process. During the scar formation, capillary buds form. There is a formation of delicate connective tissue, also known as granulation tissue. This tissue is consistent of fibroblasts that synthesize extracellular matrix and develop collagen, elastin, and ground substance, prostaglandins, as well as glycosaminoglycans. Tensile strength increases with proliferation of collagen. There are 16 different types of collagen in the body, with 80 to 90% being type 1, type 2, or type 3 collagen. For most individuals, the normal sequence of a scar formation results in minimal scarring. However, with persistent inflammation, we may see a patient resulting in extended fibroplasia, which may result in increased scarring for our patient. Phase 3, the maturation or remodeling phase. The maturation phase can last for a month to a few years. We can see a decrease in fibroblastic activity, a return to normal histochemical activity, and a remodeling of the tissue along the lines of tensile force. We may also see the formation of scar tissue. Depending on how the collagen fibers are laid down, the scar may be very noticeable or very minor, depending on the size, length, shape, and location of the wound. To decrease the appearance of scars, keep them out of sunlight or rub sunscreen on them when a patient is out and about. Scar tissue is very tender, much like a baby's skin, and can even get sunburned. When a scar gets sunburned or is even exposed to sun, it can create a darker pigmentation, and therefore, to protect the new tissue, it's important to protect it from the sun. Remember, it's new tissue, so it's never been exposed to light or other harmful UV components before. Role of progressive mobilization. Initially, we must maintain some mobilization in order to allow for initial healing. As healing moves into the repair phase, controlled activity should be added. We want to work to regain normal flexibility and strength, and protective bracing may also be incorporated. During remodeling, aggressive range of motion and strengthening exercises should be incorporated, facilitating tissue remodeling and realignment. We must also be aware of pain and other clinical signs. This could indicate that we're doing too much and too soon. Exercise and healing. We want to stimulate circulation, thus increasing oxygen's delivery and healing to tissue. We need to provide force to realign collagen fibers. But we need to be aware, by providing too much force, we can also disrupt fibers. But too little force cannot provide enough oxygen, and too little force will also not provide the realignment of the collagen fibers as necessary for healing. Some facilitators or factors that help speed up healing. For the immediate care procedures, the smaller the hematoma, the quicker the repair. That means there's less damage overall to repair. The quicker the police or rice is applied, the smaller the hematoma. Remember back to that secondary hypoxic injury. Wound margin closure. If we can close the laceration immediately, ASAP, within 4 to 6 hours post-injury for best results. Therapeutic exercise. The more we can move the patient, the more oxygen we can bring to the wound site. This also helps to realign the collagen fibers during restructuring. Therapeutic modalities. What modalities can we utilize to modulate pain, promote lymphatic drainage, and enhance healing? Nutrition. Are there any vitamins and trace elements that are essential to healing? However, there is no evidence that increasing large amounts of substances that can facilitate healing. There is some evidence that suggests hyperbaric oxygen therapy may be helpful. However, most of the research has been conducted on patients with compromised healing, such as loss of function, loss of limb, or when life threatening injuries have occurred. This is much less likely a sports injury. However, many individuals have still started using hyperbaric oxygen therapy in sports therapy as well. Some factors that may hinder our healing process: pain and the patient's response to pain. Pain does not always correlate to injury or illness. Pain is malleable, which means that it can change, and it is very patient specific. Pain can be cultivated over time. Open conversations about pain are important. Therapeutic exercise. It's possible to damage collagen fibers, which may result in a delayed healing. Residual pain. If we exercise too vigorously, we can actually damage these healing tissues. The nutrition. The lack of vitamins and trace elements can hinder healing, particularly if our patients are not eating a well balanced diet or if they're restricting some of their food intake. Hyperbaric oxygen therapy. The benefits are based on theoretical benefits. What is the proof? What are the potential risks? These chambers are extremely high cost, and there's lack of clinical or scientific evidence or evidence based practice. Some factors that may impede healing: the extent of injury, edema, hemorrhage, poor vascular supply, the separation of tissues, muscle spasms, atrophy, the use of corticosteroids, keloids and hypertrophic scars, infections, humidity, climate, and oxygen tension, and the health, age, and nutrition status of the patient. All organisms are composed of cells. The property of soft tissue are derived from a structure and the function of their cells. Cells contain a nucleus surrounded by cytoplasm and are encapsulated by a cellular membrane. The nucleus contains chromosomes, also known as DNA. Functional elements of the cell or organelles include the mitochondria, ribosomes, endoplasmic reticulum, Golgi apparatus, and centrioles. Bone is not classified as a soft tissue. There are four types of soft tissue: epithelial tissues, which include the skin and vessels and the organ linings; connective tissue, including the tendons, ligaments, cartilage, fat, and blood; muscle tissue, including the skeletal, smooth, and cardiac muscle; and nerve tissue, including the brain, spinal cord, and nerves. Soft tissue adaptations. There is metaplasia, which is the transformation of tissues from one type to another that is not normal for that tissue. Dysplasia is the abnormal development of tissue. Hyperplasia is the excessive proliferation of normal cells in a normal tissue arrangement. Atrophy is a decrease in the size of tissues due to cell death and reabsorption or decreased cell proliferation. And finally, hypertrophy, which is an increase in the size of tissue without necessarily changing the number of cells. Connective tissue healing. We have cartilage healing. Cartilage has a limited capacity to heal. There is little to no direct blood supply for most cartilage in the body. There are chondrocytes and a matrix disruption that results in variable healing. Articular cartilage that fails to clot and has no perichondrium heals very slowly. If an area involves subchondral bone and enhanced blood supply, granulated tissue may be present and healing proceeds normally. Ligamentous healing follows similarly on a course as other vascular tissues. Proper care will result in acute repair and remodeling phases in the same time required by other vascular tissues. The repair phase will involve random laying down of collagen that, as a scar forms, will mature and realign in the reaction to stresses and strains. Full healing may require 12 months for ligamentous healing. The factors that affect healing are: surgically repaired ligaments tend to be stronger due to decreased scar formations. With interarticular tears, synovial fluid will dilute the hematoma and prevent clotting and spontaneous healing. Exercise ligaments are stronger. There's been a lot of arguments of exercise versus immobilization, For ligamentous injuries, muscles must be strengthened to reinforce the joint, especially in the case of ligamentous injuries. Increased tension will increase the joint stability. Tendon healing, it requires dense fibrous unions that separate the ends of the tissue, the tendon, from the muscle. Initially, the injured tendon adheres to surrounding tissues. By week 3, the tendon gradually separates, and the tensile strength is not strong enough to create a muscle contraction, usually until week 4 or 5. Skeletal muscle healing. The initial bleeding is followed by proliferation of ground substances and fibroblasts. Myoblastic cells form, which results in the regeneration of new myofibrils. Collagen will mature and orient along the lines of the tensile force. Healing can take 6 to 8 weeks depending upon the muscle injured. Nerve healing. Once a nerve is damaged, most often it cannot regenerate after injury. Regeneration may be able to take place within a nerve fiber. The proximity of the injury to the nerve cell makes regeneration more difficult. For regeneration, an optimal environment is necessary. The rate of healing may occur at 3 to 4 millimeters per day. Injured central nervous systems do not heal as quickly as peripheral nerve. Here are some various treatment approaches to help assist the healing process. We can use drugs. Antiprostaglandin agents can be used to combat inflammation. We can also use non-steroidal anti-inflammatory agents, also known as NSAIDs. For therapeutic modalities, thermal agents can be utilized. Heat facilitates acute inflammation, and cold can be utilized to slow down inflammation. Electrical modalities can be utilized to treat inflammation. There are many different variations of electrical modalities that we'll discuss in this class. For therapeutic exercise, the major aim is pain-free movement, full strength, power, and full extensibility of the associated muscles. Immobilization, while it is sometimes necessary, can have a negative impact on the injury. We want to try to avoid adverse biochemical changes that can occur in the collagen. Early mobilization, which is controlled, may enhance the healing process. Platelet-rich plasma injections, or prolotherapy. Prolotherapy are injections of an irritant, a non-pharmacological solution such as dextrose, phenol, glycerin, or lidocaine that increase the inflammatory response to increased healing can be used to facilitate strengthening or weakening connective tissue, for example, tendons and ligaments, to reduce pain. Injections can be repeated every 3 to 6 weeks. There is limited evidence to support the use of prolotherapy. Randomized clinical trials assess this technique. Third-party payers have been reluctant to reimburse for this therapeutic treatment based on the evidence. Another technique is platelet-rich plasma, also known as PRP injections. This uses the patient's own platelets to promote the natural healing of the musculoskeletal conditions. The process occurs with small amounts of the patient's own blood that's drawn into a vial and centrifuged to separate the blood into various components: plasma, platelets, and white blood cells, and red blood cells. Red blood cells are drained away. Platelets, white blood cells, and some plasma are centrifuged again to separate the platelet-rich plasma from the platelet-poor plasma. Anticoagulant is added to prevent platelet clotting. The PRP is then injected into and around the injured tissue. Concentrated platelets release bioactive proteins. Growth factors and signaling proteins stimulate wound healing and tissue repair via stem cells within the PRP. The PRP increased growth factors in the area by as much as 8 times. This usually increases pain for about 5 to 10 days following injection. The number of injections depends on the type of condition, the severity, and the age of the patient. This is still considered a relatively new technique. There are relatively few randomized control study trials for PRP, but most offer pretty strong supportive evidence. However, this is a fairly expensive treatment costing around $1,000 per injection, and some insurances will still not cover this as it's still considered an experimental therapy. Bone healing is a little bit different and occurs in 3 phases. The acute inflammation lasts for approximately 4 days. During this phase, a hematoma forms, vasodilation and edema occur, And the next phase, the repair and regeneration. Osteoclasts reabsorb the damaged bone tissue. Osteoblasts build new bone tissue, and a callus forms. During maturation, some shape changes to the overall structure and integrity to the bone forever is altered. Acute fractures have 5 stages. There's a hematoma formation, a cellular proliferation, a callus formation, ossification, or remodeling. A hematoma within the medullary cavity occurs and surrounds and develops the tissue during the first 48 hours. The blood supply is disrupted by the clotting vessel and cellular debris. Osteoblasts fill the internal and external calluses to immobilize the site. Calluses are formed by bone fragments that bridge the fracture gap. Hard calluses become more well-formed as osteoblasts lay down callus bone replacing the cartilage. Remodeling begins with crystallization of calluses. Bone continually adapts to applied stresses, also known as Wolff's Law, balancing between the osteoblasts and osteoclastic activity. Time required is dependent upon various factors, such as the severity and the site of the fracture, the age of the patient, and the extent of the trauma of the injury. The time for healing ranges from 3 to 8 weeks. Pain is a major indicator of injury. Pain is an individual and subjective response, meaning no two patients will describe and respond to pain the exact same way, despite having the same injury. There are 4 sources of pain: cutaneous, deep somatic, visceral, and psychogenic. Cutaneous pain is sharp, burning, bright, and can have fast or slow onsets. Deep somatic pain originates in tendons, muscles, joints, periosteum, and blood vessels. Visceral pain begins in organs and is diffuse at first and may be localized. Psychogenic pain is felt by the individual but is emotional rather than physical in nature. Acute versus chronic pain. Acute pain lasts less than 6 months. Chronic pain lasts longer than 6 months. Chronic pain is typically classified by the International Association for the Study of Pain as pain that continues beyond the normal healing time. Referred pain is pain that occurs away from the actual site of injury or irritation. This is known as referred pain. Referred pain may elicit motor or sensory responses. There are 3 types of referred pain: myofascial, sclerotomic, and dermatotic. Myofascial pain appears as trigger points of small, hyperirritable areas within muscle, resulting in the bombardment of the central nervous system. Both acute and chronic pain can be associated with myofascial trigger points. Sclerotomic pain causes deep aching and poorly localized pain. This can be projected into multiple areas of the brain, causing depression, anxiety, fear, or even anger. Dermatomic pain is sharp and localized. Nociceptors are pain receptors. These are free nerve endings sensitive to extreme mechanical, thermal, or chemical energy. They're located in the meninges, periosteum, skin, teeth, and even some organs. Pain information is transmitted to the spinal cord via myelinated C fibers and A delta fibers. Nociceptor stimulation results in the release of substance P. There are 3 primary mechanisms of pain that we will look into and accept: the gate control theory of pain, the descending control theory, and the release of beta endorphins or opiate control pain theory. Gate control theory uses sensory information from cutaneous receptors entering A-beta afferents to the dorsal horn of the spinal cord. Through the delivery of sensory information, the painful stimulus and message is overridden and the proverbial gate in the brain closes. The pain message is never received. The gate control theory occurs at the level of the spinal cord. The descending pathway of pain control states that noxious stimuli can trigger endorphin release. The stimulation of pain sensory fibers is required. This causes a release of the hypothalamus and it creates a strong analgesic effect. It is more likely that multiple theories of pain control act together to mitigate pain responses. Pain assessment. Pain is best assessed with patient self-reports. We utilize multi- and unidimensional questionnaires. There are techniques for pain assessments that include the use of visual analog scales, which is very popular tools that you likely have seen, pain charts, such as the McGill Pain Questionnaire, which has over 70 classifications and descriptions of pain, activity pain indicator profiles, a numeric rating of pain scales, which asks a patient to rate their pain from 0 to 10, with a 0 being no pain and 10 being needing to go straight to the hospital or calling 911. Treating the pain. In the treatment of pain, we often use modalities. You will need to have a clear rationale for use of modalities. Modalities need to be used in conjunction with exercise. You can introduce thermal agents for pain control, utilize electrical modalities to reduce pain, and acupuncture, electrical stimulation, and even deep massage can all be used to stimulate endorphin release. Pharmacological agents can be taken orally or injected. Common uses are analgesics and anti-inflammatories. It is important to work with referring physicians or pharmacists to ensure that patients are taking appropriate medications. Pain is not just physical, but psychological also. Pain is often worse at night due to solitude and the absence of external distractions. Personality differences and cultural differences can also have an impact on the perception of pain. A number of theories relative to pain exist. We'll explore many of these in our class.